Yeah friends, hello everyone. So welcome back. So today the MCQs are, the first one is 27-year-old woman was diagnosed with Meniere's disease, presented with complaints of sudden onset dizziness and sensation of the surrounding swelling. So which of the following drugs cannot be used as a vestibular sedative to treat this condition? I will just repeat the question here. The question here is, it's a 27-year-old woman who was diagnosed with Meniere's disease, and she was presented with complaints of sudden onset dizziness and sensation of surrounding swelling. So which of the following drug cannot be used as a vestibular sedative to treat this condition? Okay, and the options are diamine hydrinate, prochlorperazine, promethazine, or it's a loratadine. Anyone wants to answer this? It's a diamine hydrinate, prochlorperazine, promethazine, or it's a loratadine. Anyone, if you want to answer this? It's a case of Meniere's disease with sudden onset dizziness and sensation of surrounding swelling. So which of the following drugs cannot be used as a vestibular sedative to treat this condition? So yeah, diamine hydrinate, prochlorperazine, promethazine, or it's a loratadine. Anyone wants to answer this? Which of the following are vestibular sedative, basically, which is not in this case? So yeah, the answer here is it's a loratadine. So loratadine is not a vestibular sedative, what we have to remember here, because see, it's a case of Meniere's disease, and for a first line of Meniere's disease, it's a specifically we do a symptomatic treatment for a Meniere's, and we have the vestibular sedative like it's a diamine hydrinate, prochlorperazine, promethazine, and it's rarely used diazepam for Meniere's disease. So yeah, the answer is loratadine. So loratadine we don't use as a vestibular sedative. So yeah, next we move on. It's loratadine is the right answer. So next we move on. It's a 25-year-old unmarried woman discovers that she is pregnant. So she wishes to undergo an abortion as it was unplanned. So within what period of gestation is this procedure permissible under the MTP Act 2021 for this patient? That is, a recent amendment was done in 2021 that to under that condition, if a 25-year-old unmarried woman discovers she is pregnant, she wants to undergo abortion. So at what period of gestation she can basically do that? So it's 12 weeks, 22, 24, or 20. So yeah, anyone? So when can be the MTP done in this case? It's a 12, 22, 24, 20 weeks. So yeah, I will just get the answer here. It's 20 weeks. So yeah, if you have a unplanned, that is, you have a contraceptive failure, and that too you are unmarried, so you can do up to MTP, you can do up to 20 weeks. So yeah, and for rape victims and all that, they have extended from 20 to 24 weeks. Yeah, 24 weeks is there. No, it's I also know it's 24, but yeah, it's which of the within what period of gestation is this procedure permissible under the MTP Act 2021? So yeah, it's given 20 weeks, but yeah, it's according to I think also 24 is the right answer. But yeah, enhancing the upper limit from 20 to 24 was special categories, that is survival for rape, victim of incest, and other vulnerable women. Okay, I understood. See, basically it's a 20 weeks is the right answer. See, 20 weeks for contraceptive failure, and if it is for other reasons, like you have for rape, victims of incest, and other vulnerable women, you have 24 weeks. But yeah, for it's a contraceptive failure, it is 20 weeks only. Okay, next we have what does the tip of the T3 spinous process correspond to? And the options are lower extent of ligamentum nuchae, superior angle of scapula, root of spine of the scapula, or it's an inferior angle of scapula. I repeat, what does the tip of the T3 spinous process correspond to? And the options are lower extent of ligamentum nuchae, superior angle of scapula, root of spine of scapula, or it's an inferior angle of scapula. Anyone wants to answer this? T3, that is a thoracic, it will go to. So yeah, if you can answer this. Okay, the answer here is C, that is the root of spine of scapula. See, T3 is basically thoracic, that is from, we have cervical, then we have thoracic vertebra. So yeah, T3 is correspond to the T3 spinous process correspond to the spine of the scapula. So yeah, here it is like superior angle of scapula is at T2, and if there is the inferior angle of scapula, it is T7. So to remember like that, see ligamentum nuchae is from at C1 to C7, then T3, T7, what I told. You have to remember that. Next we have next question: which of the following is the most common mucopolysaccharide? And the options are Hurler's disease, Hunter's disease, and Sanfilippo disease, or it's a Mortius Lamy disease. I repeat, which of the following is the most common mucopolysaccharide? And the options are Hurler's disease, Hunter's disease, Sanfilippo disease, or it's a Mortius Lamy disease. Anyone? You can just guess it if you don't know. Well, it's a biochem question. I also don't know the answer here. So yeah, if you want to answer this, the most common mucopolysaccharide is. So okay, I'll just tell you its answer is MPS. That is not the answer is C. That is Sanfilippo disease is the most common mucopolysaccharidosis. So yeah, followed by Hurler disease and Hunter's disease. So basically, it is due to the deficiency of enzymes involved in the degeneration of heparin sulfate, and it is characterized by severe CNS involvement with mild somatic involvement. So yeah, it is basically disproportionate involvement of CNS. That is it's a unique feature of MPSC, that is the mucopolysaccharidosis. So you have to that I was talking about Sanfilippo disease, that is MPS3. Next we have it's a Richter sign. Richter sign evaluates skeletal maturation using the ossification of what? And the options are iliac apophysis, olecranon apophysis, tri-radiate cartilage, or it's a tibial tubercle apophysis. I repeat, it's a Richter sign, and the Richter sign evaluates skeletal maturation using the ossification of what? Iliac apophysis, olecranon apophysis, tri-radiate cartilage, or it's a tibial tubercle apophysis. Anyone wants to answer this? You should know what is a Richter sign, otherwise you won't be able to tell. Richter sign is basically it's the skeletal maturation using the ossification of apophysis. So anyone? Okay, it's the Richter sign only. I will just tell. Richter sign evaluates the skeletal maturation using the ossification of iliac apophysis. So the answer there is A, that is the iliac apophysis is the right answer. And basically we use this sign to predict the worsening of scoliosis and in the planning of corrective surgery. So yeah, it's a Richter sign we use for ossification of iliac apophysis. That is skeletal maturation for by using the ossification of iliac apophysis. Next we move on. It's a diastolic BP of 25 women aged between 18 to 60 years are recorded. The mean data was 70 mm with a standard deviation of 10 mm. So what will be the fifth percentile value? Options are 40, 53.6, 67.5, or it's 89.4. I will just repeat, it's a diastolic BP which you are taking, that is you are taking 125 women, there are 125 patients, you are taking a diastolic BP with age is between 18 to 60, mean data is 70, standard deviation is 10 mm. So what will be the fifth percentile value? Options are 40, 53.6, 67.5, or it's 89.4. So yeah, Z value for the fifth percentile, if you can tell. So yeah, there is one formula, that is Z is equal to H minus mu by delta. So yeah, see it's basically PSM question, and every time it comes I am only confused. So yeah, we are answering 53.6. It's a formula here, that is Z is equal to H minus mu by sigma. So yeah, it's like minus 1.645 into 10 plus 70, and all that comes to 53.6. So you have to remember this Z value with the formula. So yeah, next we move on. What is the most common cytogenetic abnormality in patients with Polycythemia vera? And the options which they have given is JAK6 mutation, it's a JAK2 mutation, JAK8, or JAK4 mutation. I will just repeat, what is the most common cytogenetic abnormality in patients with Polycythemia vera? Options are JAK6, JAK2, JAK8, or it's a JAK4 mutation. Anyone wants to just answer this If you know the answer is better only. So yeah, it's a Polycythemia vera. We have discussed it. I think 2 days back we have discussed the same question. It's a mutation of what? Polycythemia vera. Anyone? Okay, the answer I will only tell it's a JK mutation. So yeah, it's a case of a JK mutation, and the other condition also where we use JK mutation, that is Polycythemia vera, essential thrombocythemia, and primary myelofibrosis. So yeah, you have to remember this JK2 mutation in all the 3 conditions. So yeah, next we move on. The next question we have is the components of Gardner syndrome are all except desmoid tumors, brain tumors, osteomas, or dental abnormalities. I repeat the question. The question here is the components of Gardner syndrome are all except desmoid tumors, brain tumors, osteomas, or dental abnormalities. Anyone wants to answer this? If you can answer, it's Gardner syndromes are all except what? So the answer here is B. That is basically it's a brain tumor. So brain tumor. So yeah, brain tumor we don't include in case of Gardner syndrome. And Gardner syndrome basically consists of what? It's osteomas, dental anomalies, desmoid tumor, polyposis colon, or it's a epidermal inclusion cyst. So yeah, basically we have the components of Gardner syndrome which I told. But yeah, brain tumor is not a part of Gardner syndrome. So you have to remember that. And yeah, there is one more syndrome, that is Turcotte syndrome. In Turcotte syndrome, basically it includes brain tumor and colorectal polyps. So you have to remember in that way. So next we move on. It's next question we have. It's a time taken. The time taken for blood to transfer the pulmonary capillaries at rest is, and the options are 1, 0.1, 0.3, or it's 0.75. So it's in seconds. We have to tell in seconds what is the time taken for the blood to transverse the pulmonary capillaries at rest. 1, 0.1, 0.3, or it's a 0.75. So you want to answer this? I think today is Sunday, so no one wants to come only to this session. Answering is different. So yeah, the answer is 0.75. So yeah, 0.75 is the right answer. It's a time taken for the blood to transverse the pulmonary capillaries at rest. So yeah, and it's 0.3 seconds or less during exercise. You have to remember 0.75 during rest and 0.3 during exercise. So yeah. Okay, next we move on. While recording the detailed history of a patient with symptoms of tuberculosis, you note that his home is overcrowded. So according to the accepted standard against overcrowding, how many people can 3 rooms accommodate? Basically it's a PSM question, and okay, the options are 4, 6, 5 and 7. So I repeat the question here. The question here is, it's a PSM question, and the question here is, while recording the detailed history of a patient with symptoms of tuberculosis, you note that his home is overcrowded. So according to the accepted standard against overcrowding, how many people can 3 rooms accommodate? Options are 4, 6, 5 and 7. So yeah, if you can tell. Anyone wants to answer this? It's 4, 6, 5 and 7. So okay, the answer is, if you don't want, it's according to the standard protocol, that is, the answer is 5. So in 3 rooms we consider there should be 5 members. So it's like that. See, 1 room 2 person, 2 rooms 3, 3 rooms 5, 4 rooms 7 and 5 rooms 10. So yeah. So the accepted standard according to this also is 3 rooms 5 person should be there. Next we move on. It's a case of, it's an ophthalmic case, and the question is, a patient presents with photophobia and blurring of vision. So on examination the eye appears as shown below. What is the mainstay of the treatment? Okay, I cannot show you, but yeah, I can just tell what is it. It is basically, it's a case of uveitis. So yeah, it's a case of uveitis, and in this case the patient comes to you with photophobia and blurring of vision. So what is the drug of choice or mainstay for this treatment? Options are antibiotics and cycloplagids, steroid and cycloplagids, antibiotics and steroids, let's say immunosuppressants. So yeah, if you can tell the answer, what is the mainstay for this treatment or drug of choice, or what you use for uveitis. So yeah, it's a case of uveitis, and okay, the answer is B. So for the uveitis patient, the mainstay that is the treatment of choice is steroids and cycloplagids. So yeah, and the steroids are the drug of choice for uveitis, anterior uveitis, sorry. And yeah, why we give steroids? We give steroids because basically steroids reduces the inflammation. So yeah, that's why it's an anti-inflammatory effect. So we give steroids here. So yeah. Next we move on to next question. The question is, a patient has come to your clinic for a contraceptive advice. As she has a family history of breast cancer, you suggest the non-hormonal oral contraceptive to her. So what is the initial dose of drug? 30 mg on day 1 of cycle, 60 mg on day 1, 60 mg on day 14, or it's a 30 mg on day 14. So I repeat the question. The question here is, it's a patient who comes to you with a contraceptive advice, and as she has a family history of breast cancer, you suggest the non-hormonal oral contraceptive to her. So what is the initial dose of this drug? If you know the answer, you can tell. 30 mg on day 1, 60 mg on day 1 of cycle, 60 mg on day 14, or it's 30 mg on day 14. So yeah, if you can answer this. So yeah, I'll just tell the answer here if you don't know, because mostly no one is replying today. So the answer is 30 mg on day 1. So see, first thing, which is that is a non-hormonal oral contraceptive what we give normally. So yeah, we give that is a centroman. Centroman is a non-hormonal oral contraceptive we give to a patient who has a history of breast cancer. That is, yeah, you have a history of breast cancer. So yeah, we give us 30 mg on day 1 of cycle. So yeah, it's a centroman, or we can also call it as ormeloxifene. It's a synthetic non-steroidal contraceptive. So yeah. Next is it's a OBG question. So now a patient comes to you, she is 28 years old, P1L1. So a patient is 28 years old, P1L1, and she presents to you with a heavy menstrual bleeding and occasional spotting between the cycles. So what is the first investigation to be done here? It's a USG abdomen, pap smear, urine beta HCG, or it's a transvaginal ultrasound. So yeah, you can tell the answer if you know the answer. Question I just said, it's a 28-year-old P1L1 woman, heavy menstrual bleeding, and there is occasional spotting between the cycles. So what is the first investigation we will do? Ultrasound abdomen, pap smear, urine beta HCG, or it's a transvaginal ultrasound. So yeah, it's a very basic question. It's like if a patient generally comes to you with for normal also, the patient comes to you with heavy menstrual bleeding and occasional spotting between cycles, what you will do first? And that too is 28-year-olds. 28 is a reproductive period. So yeah, first and foremost you will think of pregnancy. It can be abortion or something like that. But first, if it's a reproductive age woman and that too heavy menstrual bleeding, you have to go for that urine beta HCG. So you will consider urine beta HCG for a patient like this. Heavy menstrual bleeding and occasional spotting, that too in reproductive age group. So yeah, this is done to rule out pregnancy. Yeah, absolutely. And otherwise, pap smear, abdomen, USG and all that you can do. But yeah, its answer there is that is a urine beta HCG. So next we move on to a case. It's the peripheral smear of a patient with chronic fatigue is shown below. So the mark finding is seen in all of the findings except. Okay, I'll just tell you it's a image they have given. I'll just tell you what is basically what they have given in the image. It's a whole jolly body. Yeah, it's a whole jolly body, and the question is that the patient is having a chronic fatigue, and the mark finding is given that it's a whole jolly body. So it is seen in all conditions except. So basically you have to tell which condition you don't see a whole jolly body. And the options are sickle cell anemia, hereditary spherocytosis, that is, then we have a paroxysmal nocturnal hemoglobinuria, and last is thalassemia. So yeah, anyone? In which condition we don't see a whole jolly body? Sickle cell anemia, hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria, or it's a thalassemia. I think I am only speaking today. So yeah, okay, the answer is C. That is, it's a except paroxysmal nocturnal hemoglobinuria, whole jolly body will be seen in all. That is sickle cell anemia, hereditary spherocytosis, and thalassemia. So yeah, so you have to remember this question. There is nothing to tell in that. So yeah, paroxysmal nocturnal hemoglobinuria will not have whole jolly bodies. So yeah, next question we move on. It's a question of, it's a big question, I think. Yeah. So the question is C. C, what was the answer? I don't remember the options basically. What was C? Yeah, it's a C was the right answer. So yeah, next we have, it's a 55-year-old. See, the name is when I see Elapide, I'm like, it's a snake. Elapide, why that's okay, sorry. So yeah, next question we have, it's a 55-year-old man visits the neurology OPD with complaints of tremors in both his hands since the last few months. So he gives a history of spilling coffee on himself while sipping it. Then on examination, there is a significant Howell Jolly. Yeah, Howell Jolly only I was telling. So yeah, where I was, I will just repeat. It's a 55-year-old man who visits the neurology OPD with complaints of tremors in both his hands since the last few months. So he gives a history of spilling coffee on himself while sipping it. On examination, there is a significant worsening of tremors towards the end of finger to nose testing and head nodding movement. So which anti-epileptic is approved for this condition? So yeah, it's a big question. I'll just tell what is the case. It's a case of, if anyone knows the answer you can tell, but yeah, it's a case of essential tremors. Yeah. So yeah, just tell me what is the drug of choice for essential tremors. It's a phenobarbital, phenytoin, primidone, it's a valproate. Anyone? So what is the drug of choice for essential tremors? Phenobarbital, phenytoin, primidone, or valproate? So yeah, if you can answer this. So okay, the answer here is C, that is primidone. So primidone is basically, see, normally in essential tremors you think of beta blockers, but yeah, beta blockers are given, but we have to think of primidone also. Primidone it's a barbiturate, that is, it acts as a GABA enhancer. So yeah, primidone we have to give with the beta blocker for essential tremors. And the history, see if C is the right answer. So the history is like that. I just told it's a 55-year-old, tremors in both his hands since last few months. History of spilling coffee on himself while sipping it. Examination, there is significant worsening of tremors towards the end of finger to nose testing and head nodding movements. Yeah, primidone is the right answer. Next we have, in a cardiac arrest patient, what is the dose of epinephrine you would prefer to use? Options are 10 ml of 1:1000, 10 ml of 1:10,000, 10 ml of 1:10 lakh, or 10 ml of 1:1 lakh, or 1 ml of 1:1 lakh. So yeah, I just repeat, it's a cardiac arrest. It's a very important question. If you know, they just tell us that is epinephrine, no? Yeah, they just tell us we give epinephrine in case of cardiac arrest and also in case of anaphylactic shock. So what is the dose of epinephrine in anaphylactic shock and as well as in cardiac arrest? They are both different. So yeah, I just repeat, it's the patient is cardiac arrest patient here, and what is the dose of epinephrine would you prefer to use? And the options are 10 ml of 1:1000, 10 ml of 1:10,000, 10 ml of 1:1 lakh, or 1 ml of 1:1 lakh. So yeah, anyone wants to answer this? So okay, the answer is B here. B, that is 10 ml of 10,000, 1:10,000. Basically, in a patient with cardiac arrest, the epinephrine, the dose what you give is 10 ml of 1:10,000. So yeah, I have to remember that. And there is one more in anaphylactic shock also. I don't remember. I think it's 1:1000 in that case. But yeah, in this case it is 10 ml of 1:10,000 is the right answer. Epinephrine dose. So next we have, it's an 8-year-old child presents with skin lesions suspected to be molluscum contagiosum. So how is the diagnosis of this condition typically made? Options are viral culture, skin biopsy, PCR for viral DNA, or it's a clinical appearance. So I just repeat, basically it's a case of molluscum contagiosum. It's a 8-year-old with skin lesions and you suspect it's a molluscum contagiosum. So how is the diagnosis of this condition typically made? viral culture, skin biopsy, PCR for viral DNA, or it's just clinical appearance. So yeah, if anyone can tell this answer if you want. It's a case of molluscum contagiosum, and what is the diagnosis you will make? Basically, what is the investigation of choice? Options I said it's viral culture, skin biopsy, PCR for viral DNA, and it's a clinical appearance. So yeah, if you can tell the answer. Okay, the answer here is it's a D only. We don't, by only clinical appearance only we can tell it's a case of molluscum contagiosum. Why? See, we can see the image also they have given here. I can't show you, but yeah, it's a pinky wart like with characteristic dimple will be present at the center. So you will understand it's a case of molluscum contagiosum, and there will be not associated with inflammation or necrosis in this condition. So yeah, I just tell it's a pinky pearly wart-like lesions with a characteristic dimple on the center and not associated with inflammation and necrosis. So yeah, skin biopsy can be done, but diagnosis is not certain in this condition. So yeah, next we have an intern placed an intercostal drainage tube in a patient. So which of the following steps is incorrect? Options are A. He identified fifth intercostal space anterior to the mid-axillary line to place the tube. Second is inserted tube along the lower border of upper rib. Third is dilated tube posteriorly to prevent injury and incise and digitally explode. So it's an easy one. We have seen in our postings and casualty also, we have seen we put a ICD tube. So yeah, if you are an intern, you place an intercostal tube in a patient. Which of the following is incorrect? I repeat, what's the following incorrect? Options were identified fifth intercostal space anterior to mid-axillary line to place the tube. Second was inserted tube along the lower border of upper lip. Third was dilated tube posteriorly to prevent injury. And fourth is incise and digitally explode. Anyone? Which is incorrect here? Yeah, if you can tell. There's a triangle of safety and all that. Okay, you know that. But yeah. Okay, the answer is B. See, they have written B, that is inserted tube along the lower border of upper lip. No, we never put it on the lower border of upper lip. Yeah, B is the right answer. We generally put it on the upper border of lower lip. We have to prevent there is a neuromuscular bundle at the lower border of upper lip. So that's why we don't put them. We just put at the upper border of lower lip. So yeah, and we usually put at the fifth intercostal space. That one is the right answer. That is anteriorly to mid-axillary line, and it is posterior. The tube is dilated posteriorly to prevent injury, and yeah, we can incise and digitally also explode. So yeah, triangle of safety. So they have given here the boundaries. It's anterior to mid-axillary line, above the level of nipple, and that is below and lateral to pectoralis major muscle. So yeah, triangle of safety. Next question we have, which of the following statement is true regarding the modified Duke criteria? So what is a where do we use a modified Duke criteria? Anyone? Just tell me. I will just tell the question, but if you can tell where we use a modified Duke criteria. Anyone wants to answer this? Okay, I will only tell it's basically infective endocarditis. Yeah, it's a case of infective endocarditis. We use modified Duke criteria. So yeah, the options are, which of the following is true? First one is single positive blood culture for Hackett. Hackett means HACK. Hackett group is major criteria. Single positive blood culture for Corzilla. Burnett is a major criteria. Yeah, in defective endocarditis. So C, that is complete dehiscence of prosthetic valve, and D, that is documentation of 4 minor criteria allows a clinical diagnosis. So yeah, we have a criteria for Duke criteria, that is 2 major, and we have used 2 major, or it's like 1 major plus 3 minor or 5 minor criteria. So yeah, it's a long question. I'll just tell the answer here. Basically, there should be a single positive blood culture for Corzilla Burnett as a major criteria. Yeah, it is there as a major criteria. So yeah, just remember, in case of infective carditis, we use some modified Duke criteria, and that too when we tell it's an infective endocarditis, only when we have a 2 major criteria. See, there is a many criteria. I can't just tell the criteria like that. So just read that. And yeah, we use a 2 major criteria to confirm, or we can use a 1 major, 3 minor, or 5 minor criteria. So yeah. Next we have, this I think you will tell it's a recent question. Identify the wrong match regarding COVID-19 vaccine. So it's like Pfizer, that is mRNA based vaccine. Covaxin, it's an inactivated vaccine. Moderna, that is a recombinant DNA vaccine. Or the last one is AstraZeneca, that is a non-replicating viral vector vaccine. So I repeat, which is the wrong match? Basically, I have to tell which is the wrong match regarding the COVID-19 vaccine. I repeat, it's a Pfizer, that is mRNA, Covaxin, inactivated vaccine, or Moderna, that is a recombinant DNA vaccine, or the last one is AstraZeneca, that is a non-replicating viral vector vaccine. So yeah, if you can tell the answer, which is the wrong match here. Okay, the answer only I will tell. See, the answer is C, that is a Moderna. They have given it's a recombinant DNA vaccine. No, it's not a recombinant DNA vaccine. It's also a mRNA vaccine like others. So yeah, I will just tell the options were Pfizer. I'll just tell the right options. That is the Pfizer. Pfizer is the mRNA vaccine. You have to remember. Covaxin, it's an inactivated vaccine. Moderna is the right answer. Moderna is basically mRNA based. It's not DNA. It's a mRNA. And AstraZeneca, that is a non-replicating viral vector vaccine is the right answer. Yeah. So the right answer is C. But what I was telling, D is basically it's a right choice. That is AstraZeneca is a non-replicating viral vector D vaccine. So yeah, we'll move on. Yeah, this I think you might be knowing. I don't know the answer here. So yeah, the question is subfamily of CYP3A4 is CYP3A4. It's a very easy question if you know. The question is subfamily of CYP3A4 is. Options are CYPA, 3 and 4. I don't know why they give like this, but yeah. Anyone wants to answer this? CYPA, 3, 4. Oh, it's that they have given. Okay, I got it. I understood. Okay, the answer is it's a very easy. I also don't know. See, the answer here is A. See, if they have given like this, like CYP3A4. Okay, so yeah, it's like 3 is the family, A is the subfamily, and 4 is the individual gene coding for one specific isoenzyme. So we have to think like that. It's because they have given 3. If CYP is okay, it's gone. It's an enzyme. So it's a nomenclature of enzyme basically. So CYP is gone. Don't need to think about that. It's then 3A4. So yeah, 3 is the family, A is the subfamily, and basically 4 is the individual gene coding for one specific isoenzyme. So yeah, the question has the answer here, but if we don't know, we cannot tell like that. So and yeah, CYP3A4 is the most abundant and carries out metabolism of nearly 50% of clinically used drugs. So next we move on. 50-year-old man who comes to the dermatology OPD and with the following painful and malodorous skin lesions over his trunk, face and scalp. So he also has a longitudinal erythronychia and a distal V-shaped niche on his nails. So which of the following genes is mutated in this condition? It's like that only. You know all the answer at the end. They will ask which of the following genes is mutated in this condition. So yeah, it's an image based question. I will just tell what is in the image. Okay, like if I tell it's okay, I will just tell the image is it shows a greasy hyperkeratotic papules. It shows a greasy hyperkeratotic papules and nail changes, as I told. It's a nicking and all that. So yeah. I also don't know this question, the gene answer. So yeah, it's a case of Darier's disease. I will just tell it's a case of Darier disease, and you have to tell the answer. What is the mutation of Darier's disease? ATP2C2, ATP2A2, ATP3A2, or ATP2C1. So anyone, if you know, okay, you think and tell. Till that time I will just read what is it. It's an autosomal dominant condition that occurs due to dysfunction of SERCA, that is SCRCA2 calcium channel, which is essential for desmosomal function, and it results in acantholysis and dyskeratosis. So yeah, if you know the answer, Okay, I will only tell. The answer is there is a mutation of ATP2A2 mutation is present here. So you have to remember this. And Dyer's disease. And nail changes I told, there will be a longitudinal erythronicea will be there. And leukonicea also. So next we have last, I think 3 questions are there. Yeah, next we have which of the following events would not occur in NREM sleep. It's an interesting one. So which of the following events would not occur in NREM sleep? Options are nightmares, night terrors, sleepwalking, or it's a bruxism. That is bruxism, BRUXISM. So I will repeat, which of the following events would not occur in an NREM sleep? Yeah, ATP2, yeah, that was the right answer. So I will repeat again, which of the following events would not occur in NREM sleep? Options were nightmares, night terrors, sleepwalking, or it's a bruxism. Anyone? You know the cycle of REM, NREM and all that. If you now can tell if options were nightmares, night terrors, sleepwalking, bruxism. No. Okay, the answer there is basically nightmares. See, nightmares you see in REM. See, in I think what I know is I am right in that case. I think, yeah, bruxism and all that is NREM. See, what I remember is what I know is NREM comes first, then REM comes first. Am I right or wrong? I think I am right. Yeah, it's bruxism. No. See, what I remember is NREM comes first in sleep, and then we have REM. And REM is basically you have a deep sleep. So yeah, the options is nightmare is the right answer. Nightmare you will not see in NREM sleep. Night terrors, sleepwalking, and bruxism you will see in NREM sleep. But yeah, in REM sleep you will see nightmares. So yeah, and you know the stages. It will be 1, 2, 3, 4. And all that stages are there. Bruxism is basically what? It is basically teeth grinding. You are grinding your teeth. It occurs in stage 2 NREM sleep. So remember. So it's a stage 2 NREM sleep, and the answer here is nightmares. It occurs in REM sleep. Next we have a 56-year-old female patient presents to you with progressive dysphagia for solids. Can you enumerate NREM and REM disorders? Okay. It's basically event in disorders you are asking, or it's the stages you are asking? I think you are asking stages or. See, I'll just tell the events which occur in NREM. That is, we have somnambulism also is sleepwalking, that only. Sleep terror, nightmares, night terrors, it also occurs in NREM. Nocturnal enuresis also occurs in NREM. Okay. So I will just tell the events. I understood your question. You are asking the events which occurs. Okay. In NREM we have, that is sleepwalking, that is somnambulism, sleep terror or night terror, and then nocturnal enuresis also in NREM. And in REM we have nightmares, nocturnal penile tumescence, and narcolepsy. It's there in REM sleep. And others what we have is bruxism, frontal lobe epilepsy, and sleep talking. It occurs in NREM. Yeah. So I think you got it. Hopefully you got it what I said. So I'll just repeat for the last time. See, NREM we have somnambulism, sleep terror, night terror, nocturnal enuresis. In REM we have nightmares, nocturnal penile tumescence, narcolepsy, bruxism, frontal lobe epilepsy, and sleep talking. So yeah, that's what. Now what I was discussing, it's a 56-year-old patient who comes to you with progressive dysphagia for solids, loss of weight, and loss of appetite. A barium swallow done is given below. What is the most probable diagnosis? So yeah, it's a barium swallow which they have given, and it shows the irregular narrowing mucosal distension and shoulder margins. See, if they ask you there is a progressive dysphagia for solids, so first thing what comes to mind is a carcinoma. So I told the answer. Sorry. Yeah, first thing that what comes to the mind is carcinoma only, because it's for solid. Because normally when you have a tumor or something like that, it's for solids. Then only it occurs. So yeah, it's a dysphagia for solids, loss of weight and loss of appetite. And barium will also, it will show a tapering will be there. So yeah, it's like I told the answer. The options were carcinoma esophagus, diffuse esophageal spasm, esophageal leiomyoma, or it's a esophageal web. Yeah, I told the answer. The answer was carcinoma esophagus. So yeah, I will just tell what is CA esophagus. I will just tell what are the appearance in barium mill. For that, see, if you have a diffuse esophageal spasm, you will be having a cork through appearance of esophagus on barium mill. Yeah, apple core appearance. You are right. We have done this, I think, this one. So yeah, esophageal leiomyoma is the most common benign tumor of esophagus, and barium swallow you will have a discrete ovoid mass. Okay, and that is its classical finding is semilunar fill-in defect, which they have given the image also, but I cannot show you. And the esophageal web, you know, it's a esophageal constriction caused by thin mucosal membrane. See, esophageal web, I think you know it's okay. Just tell me, I know this. If you know this, see, just tell me esophageal web. Where do you see esophageal web? It's a syndrome, I think. What I remember. Where do you see esophageal web? Anyone wants to answer this? Otherwise, I'll only answer. So yeah, esophageal webs are esophageal constriction caused by thin mucosal membrane projecting into lumen as shown below. Okay, what I was telling, esophageal web is seen in. No one wants to answer. Okay, it's a Plummer-Wilson syndrome. Yeah, it's a Plummer-Wilson syndrome only. What I remember, it's iron deficiency anemia. It will be, and the esophageal web will be, and one more it will be there. I don't remember that one. But yeah, it's a Plummer-Wilson syndrome. The rest I don't know. The rest it is there or not. Yeah, but Plummer-Wilson syndrome I remember. It's a esophageal webs will be present. So yeah, next we have, it's a 7-month-old. It's the last question for today. It's a 7-month-old boy presents with brief episodes of head drop and flexion of the body, followed by tonic extension of arms and legs. The movement lasts for 1 to 2 seconds and occurs in several clusters per day with 15 to 30 spasms per cluster. Then EEG has been done, which shows it is suggestive of infantile spasm. So which of the following is the drug of choice for this condition? So yeah, okay, they have just given all that. Just tell me at the end what is the drug of choice for infantile spasm? Options are carbamazepine, ethosuximide, valproate, or ACTH. Anyone wants to answer this? Drug of choice for infantile spasm. And I told what is infantile spasm, all that. It's a brief episode of head drop and flexion of the body followed by tonic extension of arms and leg. It lasts for 1 to 2 seconds and several clusters per day. So yeah, ethosuximide, no, it's ACTH. Drug of choice for infantile spasm is ACTH, and they have given the EEG image. Yeah, the EEG shows hyperarrhythmia is present in EEG. I cannot show you that, but yeah, for infantile spasm, it's also known as West syndrome. So in case of infantile spasm, the drug of choice is ACTH, and basically it's a 3 to 8 months that is the onset, and there will be a hypes arrhythmia, what is shown in the EEG, as well as there will be salam spells. Salam spells are that what I told, that is a sudden dropping of head and flexion of the arms followed by tonic extension of arms and legs. So yeah, drug of choice is ACTH, that is the adrenocorticotropic hormone. So yeah, so I will just tell something in 2 minutes. I will just tell the drug of choice for some conditions. Suppose we have an absence syndrome. See, ethosuximide you said. So ethosuximide, it's a drug of choice for absence seizures. So to remember like that. See, if it's a juvenile myoclonic epilepsy, it's a valproate. And if the West syndrome, what I discussed, it's a ACTH. And if it's a Lennox-Gastaut syndrome, it's valproate. So mostly they have valproate only. But yeah, in absence seizure, ethosuximide is the right answer. So yeah, thank you so much. It's over for today. Thank you. Take care.